Welcome to the Society of Cardiovascular Computed Tomography webinar on Cardiac Computed Tomographic Imaging and Cardio-Oncology. We will report the results of the expert consensus statement. I'm Maros Ferenick, and I'm here with Juan Lopez-Mattei. We were co-chairs of this document with an excellent group of collaborators whose disclosures are here. Thank you all for contribution. We decided to do this expert consensus document in response to the need of cardio-oncology, which is a rapidly growing subspecialty for patients with cancer or cancer survivors. There are multiple guidelines or expert consensus documents from ESC, ICOS, or American Society of Echo, but no clear guidance on the use of CT. Therefore, we worked from 2019 to 2022 with experts in cardiology, radiology, imaging, cardio-oncology, and radiation-oncology. We did extensive literature review through December 2021, and we used sort of recommendations in expert consensus format because of the limited evidence from trials or epidemiologic studies. Our recommendations are strong if we all agreed, or moderate if there was a majority consensus. With that, I'll move it to Juan, who's going to talk about the risk factors in cardio-oncology CT evaluation.
Thank you, Maros. We're just here presenting the shared risk factors for cardiovascular disease and cancer. So basically, as we know, the majority of the patients that present with cancer may have overlap with cardiovascular disease, and this entails age, gender, genetics, tobacco use, etc. So we just have to keep in mind that this patient that is going for treatment might have cardiovascular risk factor if they're coming for cancer treatment, and they will need expertise to manage those risk factors because cardiovascular disease is the first cause of death in an exceedingly high rates in patients with the survivors of cancer. Next. And then there's shared mechanism with cancer and atherosclerosis. We have the inflammation, and with the inflammatory component, there's certain major drivers for cancer atherosclerosis, such as the environmental factors, age, risk factors. There's also the endothelium is vulnerable to some cancer treatments, so we have to consider those. So this cardiovascular morbidity is likely because of shared risk factors, cancer therapeutics, and other factors that we know and we still are about to discover. But there's a good example with CHIP, or coronal hematopoiesis of indeterminate potential, which is a risk factor for hematologic malignancies and an exceedingly higher risk factor for cardiovascular disease. Next. So basically, this is part of our consensus statement document where we recommend a comprehensive cardiovascular evaluation for cancer patients and survivors. And we're recommending what usually is a routine evaluation for cardiovascular disease risk factors, but at the same time, emphasis is made to consider the existing chest imaging, CT imaging, oncologic tailored imaging for chest to look for coronary calcification and consider that as part of the cardiovascular evaluation for risk factors. And this is just a pathway that helps us putting together the ASCVD risk estimation and the chest CT imaging, either non-gated or calcium score, to evaluate for the CAC burden. And according to the CAC DRS, which is what we're recommending to quantify the calcium, either visual or quantitative, you can determine what degree of intensity for preventive treatment is required. And again, this figure is for your reference. This is a simplified clinical pathway for non-cardiologists, where you have a patient in your oncology or radiation oncology clinic with newly diagnosed cancer, and for example, for doctors that are participating in survivorship clinics, a cancer survivor without established atherosclerosis and is asymptomatic, then see if they have a recent non-gated non-contrast CT scan and look for evidence of calcifications. And if they don't have calcifications, likely their risk is low or lower. And if there's presence of calcium, then likely their risk is going to be, it needs to be estimated further, and consider a cardio-oncology consult. So this is more tailored towards the non-cardiologists. Or there's oncologists that do cardio-oncology, so they definitely will take it from there as well. But I'm just mentioning that this is a simplified clinical pathway. So just mentioning some of the recommendations that we have for preventive evaluation. So recommendation 1.1, basically a comprehensive baseline evaluation for to estimate the ASCVD risk is recommended for all patients with cancer. Emphasis is that they need to have a reasonable prognosis, right? And cancer survivors. Recommendation 1.1 is that physicians reporting on cardiac chest CAT scan for cancer imaging should include a statement regarding the presence or absence of coronary artery calcium in the report. And this also includes the chest CT component of PET scans. Recommendation 1.2, in asymptomatic cancer patients, clinicians should review available non-cardiac chest CAT scan reports or images. If there is even evidence of CAC, coronary artery calcium, in a patient without history of ASCVD, measures should be taken to improve cardiovascular risk stratification and reduce ASCVD risk. Recommendation 1.21, severity of CAC in available non-cardiac, non-contrast chest CT images should be quantified qualitatively or quantitatively using the CAC-DRS scoring system. And this is a moderate recommendation because we acknowledge that not in every place there will be that availability, but we felt that it was important enough to emphasize it. Recommendation 1.3, if no previous recent non-cardiac chest CT is available, a calcium score may be considered in all cancer patients without known ASCVD, who are not in lipid lowering therapy if they have an intermediate ASCVD risk. And this is consistent with current guidelines, and the level of recommendation is moderate.
Thank you, Juan. Now I will go from sort of mostly asymptomatic patients, risk assessment patients, to patients who present to our cardio-oncology clinic with symptoms or findings of decreased LV systolic function. That's a very common in cancer-related cardiotoxicity. Now, the CT has very limited value for the evaluation of LV systolic function, only when MR or echo are not feasible for whatever reason. It's mostly the detection of obstructive and non-obstructive CAD, whether it's in context LV dysfunction or symptoms, that lead to this evaluation. Now, there are areas of future development that we discussed a little bit in the guideline that will be there in the future, extracellular volume and strain, but are not ready for clinical practice. Our recommendation for patients with possible cardiotoxicity are summarized here. Our recommendation 3.1 is that we recommend CTA, coronary CTA, for the exclusion of obstructive CAD as a possible etiology of cardiomyopathy in patients with LV dysfunction in setting of cancer therapy. This is a strong recommendation. Our recommendation 3.11 is that coronary CTA should be preferred in those patients that are at a higher risk for invasive coronary angiography in cancer patients, specifically patients with low platelets or coagulopathies, that CTA should be a preferred method. Our recommendation 3.2 is for coronary CTA should be considered to alternative for invasive coronary angiography in patients with elevated troponins where alternative possibilities diagnosis are considered, where these sort of, in quotes, mild acute coronary syndrome, where CTA really should be the right answer, the test, and we felt it was a moderate recommendation. And finally, recommendation 3.3 is that coronary CTA should be considered as the initial cardiac imaging modality in patients with stable chest pain and no prior known CAD, consistent with the most recent ACC/AHA guideline. Juan, you go next.
Definitely. So in regards to cardiac CT in the evaluation of the effects of radiation therapy, so it's important to keep in mind that these patients, before they're getting radiation treatment, where the heart is in the treatment field and is located in the chest, so they usually undergo low resolution CT that is a treatment plan. And if that's the only chest imaging that is available, which unlikely so, but let's say if at that point there's a calcification that is identified, that's something that could be used to estimate the risk. However, high resolution chest imaging should be considered non-contrast to assess for coronary calcifications. So the strength of the surveillance part is that when you're monitoring the patient, you could do calcium scores, and then you could, if there's no known history of ASCVD, and you could identify at some point if there's development of calcification to treat promptly and do the appropriate preventive care. But if they are symptomatic, it really makes sense to go the route of coronary CTA if they're symptomatic and stable. And also, you have to consider doing an echo in patients with symptoms of radiation therapy, because we know that it's related to valve disease, mostly severe AS. And then if the patient is unstable, then he has to go to the cath labs. He has to go to the cath, or she has to go to the cath lab. So it's very important to understand that patients with radiation-induced heart disease, if they have symptoms, they should undergo evaluation with echo to assess for valvular heart disease. And if they're stable, coronary CT should be important in the evaluation, because we know that from the nuclear stress data, patients with radiation-induced heart disease, it's important to understand that they have to be evaluated with echo to screen for valvular abnormalities if they have symptoms. Also, coronary CTA in symptomatic patients, and if they have unstable clinical presentation, they need to go to the cath lab. In patients that are asymptomatic, it's important to consider a yearly comprehensive cardiovascular evaluation and assess every 5 to 10 years, considering echocardiogram to assess for valvular heart disease and radiation-induced coronary surveillance with a CAC scan if they're asymptomatic. So basically, looking at this recommendation in recommendation 4.1 in asymptomatic cancer patients being evaluated prior to chest irradiation, clinicians should review available non-cardiac imaging, CT, if there's for evidence of CAC presence in a patient without history of ASCVD, and measures should be taken to improve cardiovascular risk stratification and reduce the risk. Recommendation 4.2 in asymptomatic cancer patients with history of prior chest irradiation and no history of ASCVD, a CAC scan should be considered 5 to 10 years after the last radiation therapy for evaluation of radiation-induced coronary artery disease. If there's no evidence of ASCVD, it should be considered repeating at 5 to 10 year intervals thereafter. Acquired images should be carefully evaluated for valvular and pericardial calcifications. This level of recommendation was strong. Recommendation 4.3, patient with history of prior chest irradiation and stable clinical symptoms, coronary CTA should be considered as the initial cardiac imaging modality for evaluation of radiation-induced CAD. Level of recommendation strong. Recommendation 5.1, CCT is recommended prior to planned valvular intervention in patients with radiation-induced valve disease, and this level of recommendation is strong. So cardiac CT in the evaluation of cardiac masses and pericardium. CT should be considered as part of a multimodality evaluation, especially in the patients that cannot get a cardiac MRI, or if there's calcification of masses and is felt that CT will contribute more. And also some patients are claustrophobic and they cannot tolerate an MRI. And a combination of cardiac CT and PET CT can help identify benign cardiac tumor and malignant cardiac tumor, and you can differentiate between both with a combination of cardiac CT and PET CT. These are the recommendations that are related to the previous slide. So recommendation 6.1, CCT can be used as an adjunct imaging modality in the evaluation of cardiac masses, often a complementary technique to other imaging modalities. This is a strong recommendation. 6.1, cardiac CT should be considered in patients undergoing cardiac tumor resection to evaluate for anatomical relationship between tumor and coronary arteries for surgical planning and to exclude obstructive CAD. This is a strong recommendation. Recommendation 7.1, cardiac CT can be useful to evaluate pericardial fluid and to characterize it by measuring the CT attenuation value in Half-Field units. It can be useful for evaluating pericardial thickness and pericardial calcification in cancer patients with suspected pericardial disease. This is a moderate level of recommendation. And then Maros, do you want to take us
thank
home?
you, Juan, for summarizing these excellent areas. So this is our summary slide. It shows you how we think about the cardio-oncology and use of CT in this rapidly evolving field, going from the prevention, overlap of preventative therapies and detection of risk factors to CT in the sort of treatment where patients has low function, suspected coronary disease, as well as in survivors or consequences, atherosclerosis, valvular heart disease, like in radiation, pericardial disease. I think in all of these, cardiac CT has a role and has a growing role. We would like to focus on or focus your attention on future areas of plaque assessment and quantification that's becoming routine and possible. I think this will open avenues for risk stratifying and monitoring patients. Dr. Juan Lopez-Mattei already mentioned the CHIP, clonal hematopoiesis. This is going to be a large area. And then novel therapies like immune checkpoint inhibitors that probably accelerate atherosclerosis, and we need a risk stratification, follow-up, monitoring, and treatment. These are all excellent ideas, all excellent areas of interest. There are actually first guidelines from European Society of Cardiology, really large guidelines with some evidence that don't have too much imaging, but we hope that we can come back here in probably 5 years and have not only expert consensus document, but actually full guideline. Again, I would like to thank Juan, who it was really exciting and really great to work with on this document. Thank you, Juan, for all your leadership and hard work on this. And thank you, FSCCT, for the opportunity for this group to actually provide this document. Juan, last words to you.
Yeah, I want to thank Maros. You've been a great co-chair, and I want to thank everyone that was part of this guideline consensus statement. So, really thank you, and we're excited to share this with you.